Start the presentation. This is the first week, return to normal fourth week. We have this ready for us. Next up.
Let's speak louder. Yeah, because the microphone is here.
So page shows sinus rhythm and heart rate of about 60 to 70. And we can see the short PR interval and delta wave clearly in V4, V6. I think the patient had oscillatory pathway.
Okay. So short PR. Got away. Any other comments? Cool. You're very close to the ECG screen.
The initial results were they had rate about 18 minutes and that always seen in 4, 5, 6, and 11 is negative. And so I think it is from the right side and one will be a short positive takeaway. And so I think it is from the right and boost.
Right side,
Perfect.
okay. So I would like to listen copies of thoughts.
So in addition to these, there are some subtle ST segment depression in the more lateral leads, which suggest repolarization abnormalities. However, this may be common in patients with accessory pathways, so it may not really be suggestive of ischemia. I agree that the accessory pathway is on the right side. With respect to the exact location, there's a bit of a transition from V1 to V2, which suggests a paraseptal origin, but because the R wave amplitude in V3 is less than that in V2, it's giving me a bit of confusion. But looking at the positive QRS complex in AVF, it tells me that it's from an anterior location. So I'm thinking right, either anteroseptal because of that initial transition, or right-sided, probably free wall.
So yesterday you also told me that we suspect the interceptor, but how can you explain the negative delta wave in lead 3 and AVF?
So if it's negative in 3 and AVF, then actually it's coming from posterior. So posterior and inferior moving upward. And so that is why it will be negative. It's moving really coming inferiorly.
You're confused.
3 and AVF are inferior leads.
Over the ECG, the reflects the direction of electricity, and based on ECG, always negative. The wave of the beginning area shows a negative wave, and destination positive wave. So that's why the negative delta wave suggests the location of bypass strength, because the ventricular repolarization starts there. So you see the negative delta wave in lead 3 and small negative delta in AVF. How do you think?
So then it's moving from inferior
Right.
upward.
Right. So how come it is anterior?
Yeah, so it would, if anything, would probably be a posterior septal.
Okay, you change your mind.
Yes.
Good. Okay, Padma.
I think B1 is negative and 1 is negative means right side. And also from inferior lead 2 lead is positive and 3 AV is negative, and B3 also looks like negative. So possible right preval.
Okay. And there, Dr. Lee, you know the answer. You have participated in the procedure yesterday. Proceed.
V1 show the positive delta wave, and that means not right septa, it's right free word, according to the Aruda algorithm. And lead to showed also the positive delta wave, so it could be right retro.
Everybody agree, right? Pre-all accessory pathway. How's the faculties? Dr. Hanjip Park always raise some out of box question and thoughts. No doubt. There is no. We want the initial cathode positive. B1. Yeah. Okay. Within the small uncut. Small one breed. Yeah. Within 15 seconds. So we don't definitely, according to the ECG, should consider positive. Yeah, yeah, and it should be on the, because the V1 is positive delta, according to the ECG, it should be on the left. And 3 area is negative delta and blue is positive. I think it should be on the left. Posterior subtotal. Okay, so posterior subtotal, posterior preor. Which one is appropriate? So I think that might be the discussion point of this ECG. Because if it is, everybody knows that the right side, the pre-wall bypass tract is weakest point of the surface ECG because there's no lead position, precordial lead position in the right side chest, except for the V1. But we can estimate that this patient has accessory pathway with the right side based on the precordial lead. But if it is truly pre-oral accessory pathway, usually it is away from the his bundle, so delta is more augmented, wide curves. If it is subtle, it is narrower than the pre-oral bypass. But this patient, the ECG algorithm looks like the right side pre-oral bypass tract, but the EKG is a little narrow. Some patients, the cardiac rotation and the vertical heart shows a little different precordial transition. So I could not exclude the potential septal bypass tract. And if it is really septal bypass tract, how to think? Negative delta and lead 3, and minimum delta, negative delta and AVR. So if only negative delta showing in the lead 3 in patient with septal bypass tract, that is mid-septal accessory pathway. If it is coming lower, lead 3 and AVF shows negative delta. Okay. Can you imagine the ECG vectorial direction? If it's really bottom of a crux area accessory pathway, so-called MCV or Cox accessory pathway. It is 2-3 ABF all negative delta. Okay, are you with me?
Yes.
Okay, from lead 3 ABF and lead 2. That is sequence of negative delta wave coming from the middle septum posterior the Cox MCB area. Okay, if it is anterior septal bypass tract, all lead 1, 2, 3 shows a positive delta. That makes sense because the vector direction is coming top to bottom. Okay. So ECG algorithm shows probably this patient has their pre-wall 8 o'clock, 9 o'clock direction. But if it is the septal bypass tract, we can exclude the middle septal accessory pathway. So I1, the potential at the middle septal bypass tract to the patient and patient family, the outpatient clinic. But where was the accessory pathway eventually? Actually,
Ah.
you were there.
Proceed, present.
Oh, you prepared.
Yeah,
Sorry
yeah,
about that. I
you
didn't know.
prepared.
Yeah.
You can show.
Okay, then go ahead. I didn't know.
Is the brief of advisory, the should complain, but complement the patient was palpitation with dizziness. And past medical history was known by prior medical records, but it looks like she had a scoliosis and operation. The patient had intermittent palpitation for 1 week. On April 23rd this year, local clinics showed narrow cardiac tachycardia, which resolved after IV administration 6 milligrams. After that, the patient was referred to our hospital for further evaluation. The vital sign was this, and that respiratory test was. And this was the narrow tachycardia, narrow cardiac tachycardia at the local ECG. And this was just X-ray. And as you said,
I was embarrassed to hear the laugh. I saw the Eiffel Tower, the fluoroscopy.
the tissue of normal. Our evaluation was down in the right brain. This was the procedure.
So can you add more about the procedure, repeat procedure?
No. The pathway was it right for you? About 9 o'clock, tricuspid valve. And after first found the delta wave disappeared in 2 seconds. So it was successful ablation. And Professor had more ablation in A side and B side. Finished the procedure.
So because their delta wave is generated by fusion of normal abinodal conduction and accessory conduction. So some people show minimal delta because it's a fusion bit. In this patient, when we paste the right atrium, the delta augment. We can estimate the location of bypass tract. The QRS width is alone, but if it is narrow QRS delta wave, you should suspect that. You should imagine whether this accessory pathway could be dangerous. Before procedure, every possibility should be imagined in your brain. And I was 6 years old. The KHS member of another hospital faculty member came to me and asked, I tried to ablate the right side frial bypass tract, and eventually I generated a heart block. So how can it happen? He can't ask me. It is because they're unlikely to the left side bypass tract, right side bypass tract doesn't have a leverage of long sheaths. So the catheter position is very unstable. And sometimes a moving catheter hit the AV node and to make the upload. It is completely different anatomy to the patient with atrial fibrillation. Atrial fibrillation patient has an enlarged atrium and the annular size of truncal valve is pretty big and round shape. But in the structural normal heart, especially young people, vertical heart, it's like a D shape. So actual distance from free wall to septum is quite close. So you should be careful. That's why I put the long sheath all the way to the high right atrium and curve down the catheter along the crystal terminalis. Make a better contact or stability. Okay. Any other question, comment?
When you ablate the right side free wall through pathway, do you prefer SL1 or SL2?
It doesn't matter.
Yeah, it's long.
I always use SL1 because it's I'm more familiar. We are using the SL1 shears every day. I think Dr. Om is the best to choose the proper shears. Hi.
Yeah. First is has 5, 4 right, 5, 4 left, 0, 1, 2, 3, 4. 3 higher number has long prime, long curve. I mean 4, for example, SL4 is designed at the reach to approach to the posterior septal, left posterior septal. So for example, SR4 was designed for reaching to the right posterior septal all the way around like this. However, long curvature is less freedom. So it is difficult to manipulate. If the sheet design is good for this patient, it is okay. However, the design, the SL or SR design is not good for this patient. It's difficult to manipulate the catheter. So I think a short, for example, 0 or 1 is more easy to manipulate the catheter, and we have more liberty or freedom for catheter manipulation. So I think the short is much better.
So SR1 is proper for this position.
I think so. SR1 or SL1, it is okay.
But nowadays we can use the differential shears. I'm familiar to use SR1.
What about going directly to the pump using SL?
Going back to where, how?
Like not like this, but like this.
Yeah, I told you, it's possible, but during heartbeat and the catheter is not stable, the poor contact make a high chance of recurrence, also hit the AV node and his bundle.
Even though there is pulse.
Hmm?
Even though there is pulse along.
Think about that. Even though you SL1 use catheter, if the catheter move like this, okay, it cannot make a good contact. That's why I make a U-shaped curve, and the catheter slip along the crista terminalis. Then more contact to endocardium with catheter make a better stabilize the catheter position.
if you put the catheter, the annulus and catheter like this, it's much better to met because we can use 3-4 or 1-2 or 2-3 or 3-4 electrogram.
And I taught the Dr. Lee and Dr. Pagma how to estimate the location of ventricular insertion and atrial insertion based on the electron yesterday. So please, there after the conference or next week, in the Monday, on Monday, you can see how to differentiate. Because the right side accessor has the description of the very slightly. The location of the insertion and the insertion are quite apart. So you can estimate the location of accessory pathway, where it's going, estimate, imagine, and you should search the right spot of the accessory pathway. Okay, so B pacing, A pacing, you can estimate which point is most close, and of course, when you if you want to make a just one shot, one kill, that terminology became very popular in KHRS. Single ablation, you want success, so look for the accessor. That is the key.
I have two questions.
Yes.
The first is from the surface ECG.
Mhm.
You mentioned that the QRS duration
Mhm.
can help tell whether it is closer to the his or further of the his. Is there a cutoff value?
No,
Where-
no. Because I already told that it depends on degree of feature. So this patient shows a wide QRS, while augmented delta during APC. So sometimes it's very difficult to localize accessory pathway position. If the patient's standard 12-lead ECG shows a minimum delta. Yeah. When we augmented it by APC, sometimes accessory pathway location different compared to you imagine. Okay.
The second question is when ablating,
Mhm.
do you need to ablate both the atrial and ventricular ends of the accessory pathway, or you can just ablate one end to terminate the second?
Just one shot, one kill. So trace the accessory pathway potential and the signal ablation is best. So can you show me the post ablation ECG? Wow, there is a T wave, big T wave inversion, like ALVC. What happened? Is this patient has underlying ALVC? Anybody can explain it?
It's doing memory.
Hmm?
It's doing memory of the ablation.
Yes, that's memory. Because for last 29 years, including the her mother's the gestation stage 30 years, her ventricular activation pattern was pre-oxide, right? And we ablated it. Now it starts from couple 100% through the AV node. That's why the activation repolation pattern change, but it recovers. How long does it take? It
Might be days or max.
Hmm?
Days to max, it might be
days or what?
days to max.
Months.
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 Okay. So it is a sort of ion channel remodeling, right? So when I teach you the reverse remodeling of electrical remodeling in atrial fibrillation, how long does it take? Usually less than 3. Okay, and remodeling will help complete. But how do you know at this moment it's okay to wait? This patient doesn't have any risk of sudden cardiac death. Dr. So?
When I don't know the history and want to look at this ECG. I may think maybe
Mhm.
he has some coronary problems.
First. Coronary angel. Okay. And the cardiac enzyme might be elevated because we are ablated. Don't, yeah, so it's okay. Don't do coronary angiogram. Trust me, just leave it that way for a while. Okay. Tom, any other comments? Question, can please.
What if you met below the due? Okay. If the due pressure, you
Mhm.
can go below
Mhm.
and then like this.
Oh, I see. What do you mean? Sometimes the unicupolar catheter touch the annulus area. It is hard to make a contact of ablation catheter to the endocardial side. So you mean put the ablation catheter beneath the unicupolar catheter to make a better contact.
Yeah, I had 3 more patients too,
Mhm.
and I tried all kinds of things, but one patient I ablated. I met by doing that,
Mhm.
and that was better than this.
Mhm.
So, what are the experiences of?
I saw the same thing when I was junior faculty, and I realized it is easier to rotate the unicupolar catheter a little bit to atrial side and avoid avoiding the contact problem. Then the U-shaped curve ablation is better and easier. But actually, I dissected more than 30 cadaver heart, and the right side tricuspid annulus thickness is very, very diverse, depending on the cardiac position and the size of heart. Some patient has very, very thick. In that case, if we try to put the catheter contact on the ventricle side, it slip into the atrium, and if we to ablate the atrial side, it packed into atrium. So some patients is very, very difficult. Okay, thank you very much.